Should I go?
Yes, go ahead. Go ahead.
Yes, yes.
So welcome everyone to this Voice of this series of webinar from Eastern India Journal Ophthalmological Congress. We are fortunate to have President AIOSE, Dr. Mahipal Singh Sachdeva, and Honorary Secretary of All India Ophthalmological Society, Dr. Namrata Sharma, with us. Apart from our President Abhijit, Secretary Dr. Pranav Jain, Chairman Scientific Committee, and all the luminaries of Eastern India Ophthalmological Congress. So this Congress is basically to foster the exchange of knowledge and information of clinical, educational, and research part of our part of India. We are fortunate that this webinar, which is little different from the normal scientific sessions, since it has got a unique name, the Extra Mile, conceived by Satyajit and Pranav sir. This has got two topics which will be discussed, one medical and one little non-medical, but both are interesting and will require a lot of input from each one of us. So without wasting our time, I'd like to share a video of our society, and then we'll move on to the session itself. Thank you, everyone. Now, moving on to the actual webinar, that both the topics to be presented are very intriguing kind of topics, and which will require every one of us to be on our foot and will be participating. I have with me the chief moderator of this webinar, Dr. Satyajit Sinha, and co-moderator, Dr. Jhumal Chaudhary. May I welcome Dr. Satyajit Sinha. Please take over from here to conduct this whole session. Thank you.
Thank you, Dr. Vibhuti. I'd like to take this opportunity to welcome each and every one of you who are here in spite of the auspicious occasion of Karwa Chauth today. We are very indebted to you. I'd like to take this opportunity to thank my co-host, Dr. Jhumal Chaudhary from Guwahati, Assam, who will be assisting me today. I'd like to welcome Dr. Professor A.S.B. Sahai, Dr. R.C. Meher, Dr. Arvind Jaiswal, Dr. Satyajit Pal, Dr. Nagendra Prasad, Dr. K. Raman Singh, Dr. Y.C. Maiti, Dr. Tathagat De, and Dr. S.K. Mitra, who will be on the panel for today. We are very honored to have with us our President, Dr. Abhijit Ghosh, Secretary, Dr. Pranav Ranjan, and Treasurer, Dr. Sujay Samanta. In addition, we are doubly blessed by the presence of the AIOS President, Dr. Mahipal Sachdeva, who kindly consented to give his time today. And we are very, very honored by the presence of Dr. Namrata Sharma, Secretary of AIOS, who has given her time today to be with us in this Voice of East program. We have with us Dr. Love Kochgave as a speaker and Dr. Anurag Mishra, whom they will be introduced by Dr. Jhumat. I would like to request at this point of time our President, Dr. Abhijit Ghosh, to please say a few words to welcome the delegates.
Thank you, Satyajit. Thank you. It's wonderful to meet you all. Good evening. And I welcome you to this third edition of this program of Voice of the East, which is a wonderful program, and the viewer is increasing, I'm telling you. This can be only attributed to the innovative brain of our dynamic secretary, Pranav Jain, with the assistance of Devashish as scientific chairman, Vibhuti, Satyajit, and all others who have supported them. We are delighted to have with us Dr. Mahipal, Dr. Namrata, and our own Dr. Devashish, the past president. I hope you enjoy the show today and you can see what we are trying to plan and envisage basically. It is our effort, I will tell you, EIZOC is going great strides, and in the near future, we foresee that it is going to be a great force to reckon with as a regional organization. We have built EIZOC with this concept, and we have vowed to work together for an academic and fellowship atmosphere, to enjoy each other's company, in addition to promote science and build the future talents and give them the proper inputs and proper platform. Thank you very much. Enjoy this evening.
Thank you so much, sir, for your kind words. I'd like to request our secretary, Dr. Pranav Jain, to please welcome the gathering.
Welcome and good evening to this fourth edition of Voice of East and the fifth webinar during COVID times. And thanks a lot to the AIS President and Secretary, Dr. Mahipal sir and Dr. Namrata Sharma for taking out time to be with us. When there is a will, there is a way. We had a dream to deliver science and culture to the doorsteps of every ophthalmologist. Pandemic, for all its nuisances, gave us the opportunity to think beyond despair and disappointments. This enterprise is one such proactive and positive step, and more so when the intent is to fish out young talents from the East. I see EIZOC as a bridge between the state and the national societies. I'd be happy to take you down the memory lane of EIZOC. The golden journey of EIZOC started in the last century. Objective amongst ophthalmologists of East was to come to a common platform. Initiative was taken by Dr. L.C. Datta of Assam, Dr. A.N. Pandya of Bihar, Dr. U.C. Behera of Odisha, Dr. M. Singh of Manipur, and Dr. K.R. Datta of West Bengal. Professor Ranbir Mukherjee took the lead role in formation of the society and its constitution. The first EIZOC conference was held in Calcutta in 1985 under the leadership of Professor Sri Mohan Mishra from Bihar. EIZOC was formally inaugurated and constitution drafted by Professor Ranbir Mukherjee adopted in the general body meeting. Professor Sri Mohan Mishra became the first president of EIZOC. Office of the Congress was in Calcutta with Dr. Ramindralal Shah as the secretary and Dr. C. Chandi Datta as the treasurer. Thereafter, regular annual conferences started being held in different states of the East. Media meets saw the light of the day by the visionary effort of Dr. B. Gupta in 2016. I'll just like to share a few of the photographs of the mid-cons that were held from 2016 onwards. This is the first EIZOC mid-con held in Shillong in 2016, and we can see Dr. Devashish Bhattacharya, Dr. B.N. Gupta, Dr. S.C. Das sir. This is the photograph of the second EIZOC mid-con held in Imphal in 2017. This is the third one. We can see Dr. B.N. Gupta, Dr. Arvind Jaiswal sir, and the huge gathering, the houseful audience at the third mid-con at Gangtok. And the last we had in 2019, that was in Agartala, Tripura, in April 2021. And you can see the transformation from few to houseful attendance. We were supposed to have the fifth this year at in Arunachal Pradesh, but because of the COVID, we could not have it. We'll have it next year. This is the schedule that we are going to have: a fortnightly program, 2 science programs, followed by one program, general program. And every state will get an opportunity, and every state with fresh speakers, young speakers, they will be given a preference. Success is not final, failure is not fatal. It is the courage to continue that counts. And EIZOC has enough of it to continue. Thank you and welcome all once again. And we are going to have a delightful evening tonight.
Thank you so much, sir. I'd like to request our treasurer, Dr. Sujay Samanta, to say a few words on this occasion.
Thank you, Dr. Satyajit. I will take this occasion to share a few words about our journal. The Eastern Eye is an official journal, and this is the last volume that was published in 2019. And the list of the authors who published, there were 12 articles, ranging from review articles, text reviews, case reports to original articles. And one of the articles that was here published. But we realized that one annual journal is not enough for an organization such big as EIZOC. So we started started this Smart Eye concept. It is basically e-journal that we publish every 2 to 3 months. Because of the corona effect, it got a bit heavier. But our idea was to we can give opportunity to many upcoming authors who wish to publish in the prestigious journal. And then I made a bit of a self-analysis. This is the percentage of involvement of various states. And I can see like Jharkhand, Bihar, Bengal, Odisha, they are contributing reasonably. But the northeastern states, they have to come forward and contribute to the journal. Because after all, this is a body of all these states. And these are the type of articles we are getting in the journal. The majority of them are the review articles, and then we are getting case reviews, and only 18% of them are original articles. Obviously, the quality of a journal depends a lot on the number of original articles, and I would like to request the authors to concentrate more and more on original articles. So this is my suggestion. One of our goals is to get the journal indexed, have a wider participation from all the member states, and we should concentrate, authors should concentrate more and more on original articles. And the articles that we are getting, not all are protocol based, regarding the write-ups, regarding the references, regarding the files and tables. These are all given in our website. They can consult that, and they can stick more or less to the protocol that has been formulated, so that it is acceptable in other journals also. Thank you.
Thank you so much, Dr. Samanta. I would like to take this opportunity to now request our All India Ophthalmological President, Society President, Dr. Maipal Sachdev, to please bless us with his kind words, please, sir.
Thank you very much, Dr. Satyajit. All the distinguished luminaries, Dr. Sahai, Dr. Pranav Jain, Vibhuti, Subudhi, actually Dr. Abhijit, everyone are great ophthalmologists, and I think maybe we can stop the slideshow. The EIZOC.
Stop the slideshow, please, Sujay.
Yeah, the annual ophthalmological conference that you have, this is consisting of East India, and I think East India has really worked significantly as regards the progress of ophthalmology. As also, I would say that the youngsters that are coming from East India are doing yeoman service, as also I would say that from a perspective of removing curable blindness, the East Indian ophthalmologists have done very well. I would just wish to say that East India is rather close to me from my practice perspective. Maybe few of you would know that when I started and went out of All India Institute of Medical Sciences, I used to visit Guwahati once every 3 weeks and used to do about 30-40 photos in about 2 days time, Saturday, Sunday. And that gave me a lot of good exposure to FACO, as also I think it helped introduce FACO emulsification in Assam. And for Bengal, I think the first Better Sight Center that was put up, I used to carry my Hansatome, and Partha used to learn the LASIK from me. And I think therefore I have a very, very close bond with East India as regards where I am today in practice, because I think both these things helped me in my earliest days of 1996-97 when I left AIMS. But above all, I would also say that we have close bonds because Dr. Pandya and Dr. Ranbir Mukherjee were constantly examiners, and I think Dr. Ranbir Mukherjee was my examiner when I got the MD degree, and I finished my MD from RP Center. So, and all of you are really very close friends of ours, and I would say that keep up the good work. East India and the ophthalmologists there are close to my heart personally, and I would say that the work that you are doing, above all, I think the friendship that you people have, and also the way you give honor to individuals who come there, I think it's fabulous. I've also visited Odisha several times and done live surgery. Bihar also, I've done several live surgeries. So I would say the only thing is that next time you have a conference in the Sisters of the East, Far East, I have never been there. I would love to be part of that, whether I am a president or no longer the president, but I would love to be there, and I'll wish you all the success for this particular conference. So let us keep up the great work, and as was said in the beginning that despite the COVID, we will fight it back, and I think it has been great that this is your 5th webinar where you are having your East India people enlightened their skill, and a different kind of a webinar that is being held today. So all the very best, and congratulations on your continuous efforts to upgrade the skills and the knowledge of all the ophthalmologists in East India, and AIOS is always there for any kind of support and help that is required. Thank you very much.
Thank you so much, sir, for your kind words. It will be an honor and pleasure for us to welcome you always to our next meetings wherever we have. We look forward to having you with us. We would now like to welcome and request Professor Dr. Namrata Sharma, Secretary of All India Ophthalmic Society, to please bless her with her kind words, please.
Thank you, Satyajit. Thank you for inviting me. I would like to thank Dr. Abhijit Ghosh, the President of EIZOC, as well as Dr. Pranav Jain, the General Secretary, for having me here. And EIZOC, I think, has shown us the way. EIZOC has done what no other zone has done. Conglomeration of all the states in one zone, and then a community thereof, and then a society thereof, and then whether it is science or it is technology or it is culture or it is social networking, you've done it all and done it in a very united way. And I think that speaks volumes about EIZOC. EIZOC was one of the first states that I visited was Assam, Guwahati, and then I also attended the midterm EIZOC meeting at Shillong. And the love and affection and the scientific content of all EIZOC programs are really great. And I think the credit for this goes to all of you who are leaders and leaders who think on similar grounds or similar levels. I remember Dr. Debashish Bhattacharya sir, who actually said that when the conference in Kolkata would be done, it will be done by the entire zone and not by the city or by the state. And I think that is a lesson which all the other zones should also learn, because in unity lies the strength. And even while sharing the profits of a conference, I think sir was the one who said that, it should be shared by everyone. So I think congratulations to EIZOC for being so united, for leading all the other zones. I'm sure all the other zones will also should or would come up with similar conglomerations, which is the need of the hour, because in crisis situations like COVID, etc., it is best to fight it not alone, but in a united manner. And so thank you once again for having me. And I would like to thank all the members of the organizing committee of EIZOC for inviting me. And like I said, it is the voice of the East, and East has always been different. The sun rises from the East, and so does, all the new things. Thank you.
Thank you so much. Thank you so much, ma'am, for your kind words. I'd like to take this opportunity to welcome Dr. B.N. Gupta, Dr. R.C. Paul, Dr. B.N.R. Subudhi, Dr. Rajan Anand, Dr. B.P. Kashyap, Dr. J.G. Agarwal, Dr. Swaraj Bhattacharya, Dr. Saroj Tripathi. I would especially like to welcome Dr. Debashish Bhattacharya and Dr. Biraj Goswami, who will be giving the golden comments. I'd like to welcome Dr. Gunasagar Das and Dr. Debashish Das, our Chairman Scientific Committee. I would now like to hand over the mic to Dr. Jhumar, who will be introducing the speakers, Dr. Love Kochgave and Dr. Anurag Mishra, who will be starting the presentations for today. Dr. Jhumar, please.
Okay. A very good evening to all, and thank you, members EIZOC, for this opportunity. It's my honor and privilege to introduce the speakers, Dr. Love Kochgave and Dr. Anurag Mishra, who will be giving the presentations today. Dr. Love Kochgave is the Senior Consultant and Executive Director at BBI Foundation VIP and the upcoming new hospital named Netralayam. He was also the Assistant Medical Director at Shankara Netralaya, Kolkata. Before that, he's a recipient of the Grand Prize at APA CRS, and he has received various awards at national level. He has been the faculty in various national and international conferences for last 15 years and has several publications. He has been training fellows. He has been involved in development of 4 tertiary hospitals till now. He has done his MBBS from Bangalore Medical College and MS from Patna Medical College and his fellowship from SM Chennai. I would request Dr. Love Kochgave to give his presentation.
Thank you so much. And the topic that was given was very interesting. And I thank Dr. Satyajit and Dr. Pranav Jain. Probably both of you have conceptualized this topic. And what happens when suddenly these things are thrown upon you, then you start thinking what you speak about this. And then it takes some days to gather your thoughts, and this is what I'm coming with. And most importantly, this is just a personal thought, and after that, we have to open it for discussion because this is a very interesting topic and we will need inputs from all of you that what else can we do. So again, in this, what I am personally speaking is what we are doing. We are speaking for small and middle level hospitals, maybe single man practice or small group practice. We are a group of 15-20 doctors, 70 to 100 staff, and being a small center, again, there are budget constraints. So it's not that you can do everything you want. We have management constraints because the professionally trained management people are not there with you. Maximum you have is 1 or 2 with which you have to work. And whatever I am speaking is based on our own personal experience. So that may be a limited zone what I'm doing. Then when we open up, then we get other perspectives also. So let's go to investments other than equipments. What comes in and why it is particularly interesting for me, because we are in that process. We are into the process of starting a new eye hospital. So all these things we have been doing in full COVID period has been utilized in this. So that makes it much more interesting for us. First important thing is we should not, many times, many of us ignore this aspect. We have to have a good interiors because now we are competing with hospital chains like Center for Sight. Sir is already here. Large institute, Shankara Netralaya, Disha, we are competing. Again, we have to, most importantly, the patient expectations has to be met. Now, it is not that we have to pamper our patient. They have to be given good facilities. When they enter the center, they should feel good about it because only skill and equipments are not enough anyway. Now, I'll just share a personal anecdote in this. When Center for Sight Hyderabad was commissioned and the pictures came on social media, I was amazed to see the interiors of that center. So one of the meetings I asked Dr. Santosh Sonawar that what good interiors the hospital has been done. He told, yeah, it has been done very tastefully, but mind you, it is not very costly. And that has stuck with me almost 10 years now. Maybe I don't remember when that was opened. And that is same thing we realized when we started doing our new center. It is not very costly. Only thing you need is a trained person who can do it well. Charges are of an average interior center and a good interior center, maybe hardly 10-15% extra, not more than that. So that is one very important thing. Now, the most important will be a good team. If you are in a group practice, you have to build the team very carefully, because what takes years to develop can be destroyed within weeks. So, and we have umpteen number of examples for that. There are very, very few successful group practices. Eventually, all group practices start with a bang and over a few years disintegrate. So that is very, very important. Again, what are the factors that make for a successful team is what we have. We will tell our perspective first. All of us are from the same culture. All of us mostly, except for in our doctors list, except for one, probably all of us are from the same institute. So that gives a common culture. Most important, we have to be less greedy. We cannot fight for one patient, two patients. Yeah, this one went this side, this one. You have to let things go and let everyone go. Healthy internal competition is definitely encouraged, but the systems have to be fair for all, whether it is the owner of the hospital or a non-owner doctor. If the systems are fair for all, then healthy internal competition helps everyone grow. Ethical practice, basic requirement if you don't want things to go wrong. There should be there should be a bar to anything what we do. We cannot cross a line. Very, very important is ego management. All top level doctors, and it's not easy to manage everyone's ego. So whoever is at the top will have to cut down his ego first, then only the system can run. Early conflict resolution. There are many instances when we start developing negative thoughts, and then once you see someone developing negative thought, nip it in the bud, talk to that person, do the conflict resolution, understand the problems and solve it. Another important thing is when you are coming together as a group, who all get the stake of the hospital and who doesn't get the stake of the hospital. Again, it's a very difficult decision, has to be taken very carefully, because we are looking for a partnership, maybe 15 years, 20 years should last. Now comes mentors. When I was thinking, then I thought, but how can they be an investment? Yes, they are investment because you are investing a lot of time with them. And it is very, very important because they will keep you grounded. And it's a personal thing for me. I have listed my mentors over various stages of my career. One of them is among the panel, Sai sir. And what happens, because if you have a mentor, then you cannot be rash. I would say you cannot be rash, because anything you do whenever you take drastic steps, and if you are in touch with your mentor, if you are talking to them, then you are answerable to them. You have to explain it to them. And since the age difference is there, and among my, I would say, Dr. Partho Biswas, Dr. Ajay Paul are almost 15 years senior to me. So again, that age difference is there. They have that 15-year extra experience. So that helps us to know what to do, and most importantly, what not to do. So we have to make that base for us. Everyone will have it different, but be in touch with them and always talk to them regarding whatever you are facing. Another biggest of them, I would say, what we learned from him was team building, selflessness. He has never again, it's very difficult to follow that, but again, why people respect him, that in spite of creating such a huge institute, he didn't create personal wealth. So that is why he is at such a high level for everyone, support in crisis. Again, when we enter our level, when we have to support our juniors, then we understand what he did for us. In the deepest of professional crisis, when I faced, he was standing rock behind me. So that is what we have to also learn. He always had connections with family of all the doctors that were working with him. Every time you meet him, he will ask about your own family. He will know them by name. So you have to be a leader by example. Whenever in doubt, think what he would have done. And that comes when you have spent significant amount of time with them. Then that culture comes in you. Again, what we should invest in is training of staff, both doctors and paramedical staff. I've kept this picture just to explain how it works. This is the more or less the pediatric ophthalmology department passed out doctors of Shankar Nithalaya. And I was the first pediatric ophthalmology fellow. So over the years, every year they have been taking only 3-4 fellows, and it becomes a large army in a career span of 20-25 years. And what it helps you to upgrade yourself. If the paramedical staff are well trained, then again, your surgical results, the patient satisfaction increases, the patient retention increases. So you should invest time. You should invest time in training both doctors, paramedical staff, your patient operation level staff who are dealing with the patients. And also it generates a lot of goodwill and propagation of your name, of your hospital, your own brand. Another thing what we have learned is to invest in reputation management, because nowadays what happens, every patient has a smartphone. They are sitting in your hospital 10 minutes, 15 minutes, half an hour, they get irritated, and then they take one picture, put it on Google review with a nasty comment. So if you are not managing it actively, only the negative things will come on the social media and your reviews. So you have to manage it actively so that the positive comments also come. So, and most of the negative comments are picked up in your own system and doesn't go out into the social media. So that is why reputation management is important in the present days of digital revolution. Linked to that is digital marketing. Again, there are various ways, and again, it is important. Just from personal experience, we have been managing the Google listings of all our centers, and if you leave it unmonitored, like BBI Foundation, VIP, for a long period of time, we were not looking into this. And our Google review ratings were coming to 3, 3.5. So whenever a new patient is coming, they look on the internet. So these things we have to do it actively so that whatever good work you are doing reflects on your social media page. If you leave it unmonitored, then it will never come to that level. And when we are making a new hospital, you start using this medium, and again, it is ethical. What you are doing, you are showing. And as you can see, simple posts over a week's time getting 3,000 views. The hospital hasn't even started, but people are getting to know about it. So these are tools which are being used by people. If you do the analytics, you will see that in just for making this presentation, I was seeing BBI Foundation VIP last 1 month, 25,000 people have seen it on Google. So people are seeing it. So if they are seeing it, then you have to manage it properly. Again, very, very important is investment in employee welfare, like group insurance incentive, overtime, annual picnics. Test of employee welfare was COVID times. We had to, it was such a challenge that with zero earning of the hospital, how do you maintain that manpower? So that is what we learned again, that we should have enough corpus, enough savings, so that in periods of crisis like this, you are able to retain, because they had nothing, nowhere to go during this period. And if you have a happy employee, automatically it will show in the results, and result will lead to a happy patient. Then came what else? Again, with this COVID experience, definitely we should, for our, one thing is our personal finance, second is our hospital finance. So for hospitals also, monthly saving is must, so that you develop a corpus over a period of time. Investments for the crisis period we should do, whatever way we want to do, we should also invest for workplace safety, because one or two major, if incidents happens, then it reflects very bad, and so many people are dependent on you. Just a food for thought. This could be an investment for all of us. Get out of the cashless trap. This is just, I'm throwing an idea for everyone to think about it. Thank you so much.
Dr. Jain, you there?
Yes, sir. Thank you, sir, for your wonderful presentation and the points very important points which you have touched. Our next speaker is Dr. Anurag Mishra. He is a very young and dynamic surgeon. Yeah.
Dr. Jumar, before we go, we would like to have a discussion on this presentation. And we have 4 panelists over here, including Devashish sir. So we would like to have the views. Can you invite all the panels one by one to take their views?
Okay, sir.
Beginning with Dr. B.N. Gupta, please.
Okay, sir. So I would request the panelists, Dr. B.N. Gupta, sir, Dr. R.C. Paul, sir, Dr. B.N.R. Subudhi, sir, and Dr. Rajan Anand, sir, to kindly give their opinion about the presentation.
And then the golden view by Dr. Devashish Bhattacharya.
Yes, right, sir.
The mic is off.
Please unmute yourself.
Yeah, thank you, everybody. I think this topic has been very nicely covered by Dr. Love Coach Gave, and he has covered all the aspects. I would just like to add something, because the topic where to invest other than equipments, there is no fixed norms. Actually, it depends on the liabilities and the priorities of the surgeon. A beginner who sets up his practice in early 30s, his main concern is equipment, and infrastructure is secondary. In addition to that, he is busy with kids care and training and getting expertise also. In 40s, he gets some experience, gets some name and fame, and then he decides where and how to settle. And in the meantime, he has to spend in the higher education of his children also. And this is the time when his main concern comes, that is the development of the infrastructure, or suppose he is having a good infrastructure, then he will like to expand it. Enhancement of the service providing mechanism like computerization and online facilities, then technological advancements, enhancement of the equipments, upgradation of equipments. In 50s, again, after finishing his other liabilities, his main concern becomes the enhancement of the facilities or updating of equipments. And if there is some successor in the family, like son or daughter is there, then in 60s or after that, he still goes on investing in infrastructure or equipments. Otherwise, he just takes a backseat. So this is how every surgeon has to go and to meet the liability and responsibility of his family and his profession. So, thank you very much.
Yeah, BN, that was a wonderful comment from your side. But I mean, as we go forward, let us first decide one thing, that we invest in ophthalmology. I mean, we are ophthalmologists, and the first thing that we need to invest is we invest in ophthalmology. Very often it is a other experience that people invest in other things, in land, property, shares, whatever. But I think we need to invest in ophthalmology. So that's number one. Number two, the graph and the chronology of career that you said is very apt and true. When we are young, we have time, we don't have resources, that is money. So we need to invest our time. And when we have money, then definitely we should add on as many things as Love said, and taking your last piece together, that retirement, I mean, if you are not inherited, I think it is high time that all your 35 years, 40 years of value that you create, a private practice creates for itself, should join hands meaningfully at maybe 55, 60, 55 I would say, and carry it forward another, it on to somebody. So there are various arrangements by which they can be done. So these kind of collaborations are very important. Right. So I mean, taking it for the panel, we have others in the panel and we can go forward from here.
Dr. Jumar, can you invite Dr. R.C. Paul, please?
Yes, Dr. R.C. Paul, sir, kindly give your valuable opinion regarding the discussion.
Thank you, Jumar.
And this is especially for Rotish. Invest in ophthalmology.
He does, sir.
He's interested in farming these days, I've heard.
So thank you very much for this, beautiful. I must congratulate our Eastern Journal, EIZOC, the officials, the lovely society, and first of all, this innovative idea of, in this scenario of thinking about the practice. I must thank Love, actually, to my heart, actually, when you are practicing in your day-to-day life. Maybe just one or 2 points I just like to highlight. This is nothing with the finance. I learned from Devashish Bachchan. First investment is my mind process or the thinking process. When to start, how to start. So maybe in your beginning of the career, middle level of the career, or maybe in my age, at last stage, maybe going for agriculture. This is a different debate. I am not going. But what is important is which kind of nature, starting from CFAs, say Dr. Mohipal, Devashish, Disha, or BBI, or the because this is an entirely corporate segment. It's like us, global segment. Also there is charity segment. Also there is group practice. Also there is individual practice. Also there is government practice. Believe me, trust me, this is going to complement the system. So this is the biggest investment. First of all, system you have to adapt, and exactly in which location you have to start. These are nothing involved with the finance. I learned from Devashish Bachchan that if the location is accessible from the railway station or from the the bus stand, and that really is one of the eye opener for me, honestly speaking. The third point, which is going to probably we being the ophthalmologist, most of us, we remain concerned with the, I do say it is 5% of the activity. 5% means when the patient is really entering into the hospital, whichever system it is going, this is a different process of thinking. But what is most important is this, what is exactly happening in the society or in the community, because this is a vast area starting from rural to urban, semi-urban to richest people to poor people, all these things. So this is the biggest investment in which model I am going to deliver and how dearly I am connecting the aspirations of that locality, the population coming to me, and what I am delivering through my huge process. Probably this is the most important investment. I definitely will seek the comments from the other. If you ask me, the biggest investment should go how the patient will be coming to you, how your clients will be coming to you. Because the government, there is a transformation. Government is also now trying to go to this system, how they can attract the people. So there are different methodologies. Lab has done beautifully into this, but this is really one of the biggest investment. Where should we give? And last and most important one, this is if we see it as a program, the natural process of a program, if there is a doctor, some staff, some instrument, some building, some patients are definitely going to come. And basically, if we see that this is going to be a rising pattern, but after some time, if this is not being changed, that is going to reach to a plateau, definitely there will come to a downfall. So what is lab has mentioned nicely, one is succession, another is you have to change continually according to the requirement. Thank you. From my side, I think this is enough. I have taken enough.
Thank you.
Hello. Can I say something?
Okay, sir, please.
Actually, I must congratulate Dr. Love for excellent presentation, and all the panelists' view is very excellent on what investment should be. One thing I just like to add, investment on health is very important.
Yes.
If you are in a private practice, if you are not maintaining your good health, your all productivity will be lost. So always keep on investing on the health part also, a healthy lifestyle, and always be prepared for any untoward effects of your, always expect something to happen and you have to prepare for it also. So investment on health is very, very important to me as the other things are important as well.
I added one slide.
And now we must have a very fat life insurance. Very, very fat.
Yes.
Thank you, sir. Next, I would request Dr. BNR Subudhi. Right?
Yeah,
yes, sir?
Really, yes. Thank you, Dr. Jumar. And I must congratulate Dr. Love to give a detailed description of what investments other than equipments has to be done in any clinic. But I would like to say that because it's a good group practice, and there are lost a lot of members they can invest. But if it is single doctor practice, sometimes it's very difficult to invest more in the interiors other than the equipments. Because now ophthalmology, I would say, is one of the most expensive faculty compared to any other branch. Our counterparts will see the machine, surgery and everything. Orthopedics, you can say, the investment is almost nil, you can say. But in ophthalmology, I think our equipment are so expensive, and always we have to run up the company people for any mishap or any wrongdoing in the instruments. Always our investment, double or triple in the equipments. And second point, the skill of the surgeon is very important, I would say. Whatever you do, unless you deliver the goods, your hospital will not run. So definitely Dr. Lab is detailed. So I would like to say that the patient must feel happy once he enters into your hospital. Whether interior or exterior, everything has to be developed. But it needs a lot of initial investment, lot of confidence by the practitioner. When you get out of an institution, sometimes you feel very elated that once you come to your place and you will do good practice, but if the practice doesn't click, and whatever investments you have done it, sometimes it becomes, it's a really think that it's a really waste. So these are my points I would like to say, but still again I would say that congratulate Dr. La for his beautiful presentation, and definitely will be remembered by all of us. Thank you.
Thank you, sir.
Jumar, I want to make a comment.
Okay, sir. Please do.
First, I want to congratulate Dr. Love for his very good presentations, but his presentations for the group practice. For group practice is a new norms, and one thing I say about the group practice, which Mother Teresa has said, you can do good, I can't. I can do good, you can't. Both of us can do great things. This is about your group practice, but for me and the persons who is a singleton ophthalmologist, all his career of about 30 and 35 years. At this age, 60 plus or 65, how to manage the clinic, how to pass on, this thing is very important. So these things, from my opinion, is my suggestions for my generations. You can have 3 or 4 persons can pull up your money, your investment, and make a common surgical center, because nowadays the digital medical services with Government of India is going to do it in 3 or 4 times. So new ophthalmologists, young ophthalmologists, it is very difficult for them to have a NABH certified hospitals or surgical centers.
Yes.
So we can make a common surgical center in a city, in a 2-tier or 3-tier, where my young colleagues can come, do their surgery, so, or we can have in the same center the common diagnostic center. So this, the senior ophthalmologists can pull up their money and do these kind of things for the benefit of the young ophthalmologist. Thank you.
That is also a type of group practice, actually.
Yeah, it is a group practice.
Yes. Yes.
But the youngster doesn't have the money to invest that much. 4 or 5, because about 5 years back, I had a talk with Pranav, Dr. JG, Dr. SP Sinha for these things. We should have this kind of facilities in Patna.
Arvind, but see, I mean,
not practically feasible.
We are on the retirement mode. Like Nagendra is too young. See, Arvind,
not very much, sir.
नहीं, सर वो देखने से जवान और यंग लगता है सर. अब हम आगे नहीं कुछ बोलना चाहते.
We should start thinking in these lines. See, if we associate with a promising young ophthalmologist, I'm not trying to think of anything big.
Yeah.
Just engage with a young ophthalmologist of the age of, say, 35. He is fully accomplished, but he doesn't have the following and the resources and the equipment that you have. Yeah. And now let him work, and we have to give, because he has only time and he can work and give time only. But often what happens, there is a breach of trust between the senior and the young fellow. We don't बोले ये काम सीख के भाग जाएगा.
This is the problem.
That is our responsibility. करना है, उसको stake में लाना है, उसको ESOP में लाना है, gradually ownership पे लाना है, and ultimately it can mature into a retirement plan.
We can have a one webinar on this.
Financial equations that can work around these things. Yeah. And as Love pointed out, I'll talk about Love, what Love said, because he's the perfect guy to follow, I'll tell you. And
Sir will take your comments just after finishing Dr. Rajan Anand. Sir, we'll take the final comment from you, sir, after Dr. Rajan Anand.
Yeah.
Dr. Rajan Anand, sir, would you kindly give a valuable opinion?
Yeah, thank you, Jumar. Thank you, Satyajit. Love, it's what a wonderful. Am I audible?
Yes. Yeah.
Okay. Okay. That was a wonderful presentation. You had shared with me yesterday itself. I just wanted to add a few words. That his presentation was mostly about a group practice, a medium, what he calls a small. It's a medium level hospital, and we see the bigger hospitals, and we try to compete and follow what they are doing. What the current trend is, right? Whatever he said is correct. But even today, I think 50% of the patients of ophthalmology are being dealt with solo practitioners and a tier 2 and tier 3 cities. So I'll just name a few things as investment, not monetary, for these small solo practitioners in a smaller town. Because most of the big cities don't have their own patients. These are the patients migrating from the smaller towns which move to Chennai and Pune and Calcutta and get their treatment. So for a small, and I practice in a small town, a district town, I think the biggest investment that I could have made is a rapport, a personal rapport with the patient. And these elderly patients have their children in Bangalore and Pune. They go there, they visit various hospitals, they are told this is the procedure, this is the cost. They come back to you and with one line, sir, आप हमारे डॉक्टर हैं. I have shown 5 centers. आप मेरे को बताओ क्या करना है. If I do it, they are ready कि आप करो. Because you have been there with me for 25 years. So building a rapport, a personal rapport with the patient and the family at a smaller practice is very important investment. You don't have to go visit their houses for birthday parties or invite them. Give them a personal approach because that is what lacks in a larger hospital. You have a Niger system, you have automated systems, you have all the media, but one-to-one, the doctor and the patient, this relation in a small practice is a big investment. And over the time, it is not money, but this which pays you. Thank you.
Yeah, this is important in solo practice, definitely.
Yeah.
Because the children are there in Bangalore or Mumbai or anywhere, but the parents are going to stay with you only. And they will always come to us for consultation or for final opinion.
This is a difference, personal approach and the virtual or digital approach, sir.
I have a comment to make, a very small one. मुझे लगता है there are specialists of two kinds. One is काम करो, खाओ पियो, मस्त रहो, that's it. And the other group is, they eat ophthalmology, they drink and they sleep ophthalmology. And all these people who eat, drink and sleep ophthalmology, they are all big shots. Like all the people on the screen are all big shots. They all drink, eat and sleep ophthalmology. Everybody on the screen. So there are two kinds of thinking. So the view may change accordingly. So if you're really that kind of a dedicated person, then you start your practice, then you build your practice. There are two ways. Number one is you rest and wait for the patient to come. Or you work very hard, earn your name, earn your money, and then you open a hospital, and then there's no dearth of patients coming to you. And then you'll have more patients, more doctors, they'll come to you. So first of all, do good, do your best, give time to patients, and eat ophthalmology, and drink ophthalmology, and sleep ophthalmology, and follow the legends like Dr. Debashish Bhatt and Dr. Paul, Dr. Dr. Partha Biswas. He has become a legend in no time. That is a little bit of what I have to say. Thank you.
Dr. Satyajit, can you take comments from the other panelists?
I will do that. I want to do the comments from the panelists who were invited earlier. Final at the end of both the talks. So we'll take the closing comment from Dr. Debashish Bhattacharya now for this talk, and then we'll move on to the next talk now.
Right, Satyajit. Thank you. Essentially, as Ratish pointed out, and we came to the gist of this discussion, that what exactly do we want to start our careers with? Generally, we locate our practices because, you are from Patna, so you start your practice in Patna. I think the youngsters need not look it into this perspective. So, whether you are into that kind of an image that I will do the best care, whatever it costs, I will be there. Or the second one is I would be a value for money doctor where I could serve people at a fair price. So these are the first primary decisions you have to make. The department's seeing love. So having said that, the other thing that we need to place is this is the cycle of practice that as it goes. As Ratish pointed out, the location is a very, very important thing. Because where are we locating our practice? Till we are not sure we shouldn't locate it. Like Netrayam is located just in front of Shankar Netralaya, just a furlong away from Shankar Netralaya. So very strategically located. And then I would say that, as he said, today digital presence is very important. I mean, we need to see that our websites are good, our Facebook posts are good, we have a Google rating, we need to follow it up. And the most important thing is contents that we are sharing amongst ourselves. We need to understand what good work they do. Why is Love what he is? Why is Partho what he is? Because it is not only Partho. You won't see Partho's prescription in any of his prescriptions. There are people to write those prescriptions. He just signs it off, but he continuously keeps on talking. So these are other things that we need to focus and invest. These are masters. For us, as I told you before, we need to do our retirement planning. We really need to do our retirement planning. All these 35, 40 years of reputation that we have built, the faith and goodwill that we have created, we just can't just let go. Or, someday we said, no, we are not buying another machine because I'm getting old. This should not happen. We should, join hands and collaborate and go forward. So that is the little comments that I wanted to add. Thank you very much. It was a very lively discussion. I enjoyed it thoroughly. And thank you, Satyajit, and the entire team of EIZOC for choosing such a wonderful topic which could be so interactive. I've seen everybody here as participants just coming in and trying to make their point. Yes, all were so valid. Vicky's point was so valid, so.
Thank you so much, sir. Thank you so much, sir. Dr. Jhumar, can you introduce the next speaker, please?
Yes, sir. Our next speaker, Dr. Anurag Mishra. He is a very young and dynamic surgeon from Cuttack. He is the director of Radharaman Eye Hospital, Cuttack. He did his long-term fellowship in IOL and anterior segment and in pediatric ophthalmology and strabismus. He has been a speaker at several national events and in different state societies. He has several publications in peer-reviewed journals. So I would request now Dr. Anurag Mishra to kindly speak on his topic, non-ophthalmic emergency in your center. Are you ready? Over to sir.
Thank you so much, Dr. Jhumar. Thank you, Satyajit. EIZOC, not only for the platform, but also because of the fact that I always wanted to speak on this topic for a long time, and I'm really thankful my wish has been granted finally. Just about the time when I was about to establish my hospital, I realized quickly that for a long time, or for a major time in my practice, I'm going to be a standalone. I'm not as fortunate as Love is to have a team. So I invested my time into learning different non-ophthalmic emergencies that can pop up during your practice, relating to systemic conditions, how to handle them in your practice if you're standalone. And I hate taking the help of a physician or a cardiologist or a pulmonologist for every bit of them. I learned about several conditions, though the time doesn't permit to go to all of them individually, so I'll highlight on a few during the course of this discussion tonight. Good evening, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. We begin with an organ which is known as the master band of the human orchestra, the heart. So the cardiac corollary begins hereby. Why we need to look at the heart is because we need to counter the emergencies at times, and more importantly, we attempt to prevent an emergency. To counter an emergency, strictly speaking, is not our domain. That's where we do a referral. But to prevent an emergency is something we can do, and we need to learn a little pointers with regards to that. It's important to prevent the ensuing emergencies because we deal mostly with the elderly who may or may not have a cardiac history. But for every patient who needs an evaluation with respect to the heart, a cardiologist does not have to be called for. Why? We would see in a moment. Let's divide our patients into three groups. People who have no history of cardiac diseases, people who do have a history and a recent visit to a cardiologist in anticipation of a cataract surgery or any other procedure that they're likely to undergo with the ophthalmologist. And the third group are with a history, but without a recent visit. Now, out of these three groups, the middle group, patients with a history and a recent visit to the cardiologist, is the best group that you can encounter with. But what about the other two? If the patient has a history and no recent consultation with the cardiologist, should ideally be sent admitted and is situated in a cabin. Of the left subclavian artery in the cabin for 5 minutes, and the oxygen saturation, this was done much before COVID-19 came in. The oxygen saturation, the pulse and the BP were recorded in real time over a period of 5 minutes because they keep on fluctuating. So they have to achieve a level of stability before they're recorded. Pulse and blood pressure also recorded manually, and the person who does it is officially trained in that, and we can get a hell lot of information from manually recording the pulse, if not the BP. The pulse gives us more information than the blood pressure even. A bedside ECG in all cases above 75 years, if it's not done already outside, and a bedside ECG in all cases of history and without a recent visit to a cardiologist. Now, if you do a bedside ECG, you are the one who is going to read it. So there are a certain, certain clinching points in the ECG. Let's try and understand what they are. Out of all the leads that come in the ECG printout paper, lead 2 is the representative lead. Fold the paper, just focus on lead 2 because that is the representative lead. It represents the inferior half of the heart along with lead 3 and AVF. The B1 to B6 isolated leads are the chest leads and they represent the anterior and the lateral wall. Needless to mention, this is the normal ECG wave that you get to see in the paper, the P complex rising from the atrium, the QRS complex from the ventricle, and the T as the going away. Sometimes you find the U wave, but the U wave is designative of hypokalemia, it doesn't come normally. The first thing that you need to look at when you study an ECG is this thing, the ST elevation. Even the cardiologists and the physicians look at the ST elevation as the first finding from the ECG. Now, this is a normal way wherein the PQ segment and the ST segment lie on the same platform and the same level as you can see, as opposed to this, wherein the S part of the QRS complex does not come back to the midline and it stays elevated. This is what is found in lead 2 again. In lead 3 and AVF also you find similar changes most often because when you have a myocardial infarction taking place, it's the inferior leads that do show the change. Sometimes in the chest leads, the B1 to B6 leads, the ST segment is also elevated like this. However, in some other cases, they show from B1 to B4, they show a mirroring of the ST elevation in the form of an ST depression. We'll look at that in a while from now. Now, apart from myocardial infarction, ST elevation also takes place in left ventricular hypertrophy. However, in left ventricular hypertrophy, you can only see it in lead 2. The contiguous leads from B1 to B4 do not show a change. So that's the differentiating point between these two conditions. This is with regards to a patient that was supposed to be posted for surgery last week. The patient had taken a date, he had no history. He had no history. That's why I say the group of no history is the most important to look at. He had no history. The patient was posted for surgery. The day before the surgery was due, in the evening, the patient suddenly felt uncomfortable. A call came to me. I asked for an ECG to be done, and the report was sent to me. Look at lead 2 here. You can clearly see there is an ST elevation. In lead 3 also, there is an ST elevation, not very clearly dominated. In AVF, you can see an ST elevation. I think you can see that very clearly. The QRS complex does not come back to the midline. But what happens in the B1 to B4 is that there is a mirroring of the ST segment. There is an ST depression. I suspected myocardial infarction, immediately asked the patient to visit a cardiologist. The patient was admitted and treated ASAP and was safe. So these are the clues. You are the go-to doctor for that particular patient who has got no history of cardiac diseases. So obviously the patient would contact you first, and you must have these tiny little informations behind you. So this next thing that we see in an ECG is the Q wave. where the QRS complex just dips in and forms a wave. This is the Q wave. Once you see a Q wave, you confer that it's an old myocardial infarction. There's nothing fresh that is happening. It is exclusively seen in lead 2. That is why I keep on saying that lead 2 is the representative lead and has to be looked at. And patient who has this, and if hasn't visited the consultant, should do so immediately, because this does show an old MI, which might have or might not have been overlooked by the consultant who has seen the patient previously. Atrial fibrillation is another condition because it gives rise to chest pain. And in atrial fibrillation, notably, you see an absence of the P wave because the atrium does not give rise to any wave in ECG. What you see here is the QRS complex and the P wave. The P wave is not anywhere to be seen. However, the RR interval, the peak of each two RR waves is the same. Between the two RR waves, the interval is the same. So the ventricle luckily beats normally and the rhythm is generated normally, but the atrium goes into the frenzy kind of beats. So it is not enough to generate any wave. However, the patient might have angina and chest pain for you to encounter. Paroxysmal supraventricular tachycardia is something that patients learn to live with. It's almost a physiological happening. Some patients are just prone to it. Paroxysmal supraventricular tachycardia is notably featured with a regular R interval again, but the rate of the heart or the pulse rate, both of them go up. Once again, the patients become uncomfortable. They might feel a little dyspneic, but with a little bit of rest and lying down on supine position and the AC switched on, they might stay a little bit, but they do come around pretty fast enough. So the ST segment, to summarize, gives us infarction and muscle dysfunction is the most important finding to be seen, particularly in lead 2. RR interval gives us the rhythm of the ventricle in particular. Q wave tells us an old damage, and manual pulse recording, if it's feeble and not beating properly, can give us plenty of clues, particularly if the one that records it is vigilant enough to bring it to your attention. If the patient does complain of chest pain, it can be given rise to by several conditions like angina. Chest pain is constrictive, but the ECG is surprisingly normal. Atrial fibrillation gives rise to angina and thereby chest pain. Acidity and heartburn. Usually patients do give you a history of acidity being there with them for quite some time, and it can also be musculoskeletal. However, in musculoskeletal chest pains, it is usually postural. So that much about the heart. Let's go to the next organ and look at some of the emergencies that pop up in that. Syncope in succinct next. Syncope is of two types. One is cardiogenic syncope, wherein there is a transitional block that happens from the atrium to the ventricles. Once the sinus rhythm is generated from the atrium, it does not pass on to the ventricles. The heart cannot pump. In there, the RR interval is prolonged, as you can see in this lead, and the patient feels suddenly fainting. I mean, the feeling is, I cannot stand anymore. Sometimes there is the neurogenic syncope, which happens more commonly and exclusively happens because of the increased vagal tone. We call it vasovagal syncope. And in fact, actually, it's an overlap syndrome between the neurogenic and the cardiogenic conditions. The moment you see syncope happening, this is what you should be doing. The patient has to be made supine immediately because blood is not flowing to the brain, and that's the cause of syncope, basically. So if you counter gravity by asking the patient to go supine, then the blood flow is assisted with. An IVX access has to be established immediately. I hope every hospital has at least one trained nurse who can establish an IV line immediately. IV fluid has to be administered. The best fluid to be administered is dextrose normal saline, and the rate has to be a little frequent, 15 to 20 drops a minute, so that the fluid goes in and serves the purpose of serving dyselectrolytemia while also supplying some amount of crucial glucose to the brain at the same time. Complete asystole can also result from syncope. At times, the heart does not beat at all and goes into asystole. You can safely give a milliliter of undiluted atropine in the intravenous cannula, but this, my friends, is God forbid, because you also panic as much as the patient does if there is an asystole that you encounter. But, you know, even if you're an ophthalmologist, if a patient has been admitted in your hospital and does come across this, then you have to give. So it is safe. I just wanted to mention that it is safe to give a milliliter of undiluted atropine. It does not cause any harm whatsoever. apart from causing a dryness of mouth later on when the patient recovers from the condition. Hypo is the where-to. You have a lot of patients that come in who are diabetics, and more than hyperglycemia and hyperglycemic coma, what you encounter as a medical emergency is hypoglycemia. These patients complain of hunger to the extreme extent. All of a sudden, there is profuse sweating, tachycardia because of the counter-regulatory hormones kick in, particularly the adrenal hormones. They kick in and produce tachycardia. There's altered sensorium, particularly if the patient's elderly and the diabetes has been there for a long time. The tissue also develops some kind of insulin resistance. So there's altered sensorium. The tongue goes dry. And sometimes the patients land up in suspended animation-like phase. They do not respond to your commands. They do not even respond to painful stimuli at present, which is actually very, very scary. I have come across these situations. I'm sure all of you must have. So what you do is, as an immediate measure, 4 teaspoons of sugar sublingually stat as early as you can. If you have powdered glucose, which you should have in your pharmacy or your refrigerator, then it acts faster, but it is stickier. So do not overload the sublingual space with glucose because it becomes very sticky, and these patients fail to swallow. Even if you dilute that with water, they sometimes fail to swallow things and they choke. So powdered glucose, if you give, it has to be given scoop-wise or spoon-wise, and you have to ascertain that the amount, the teaspoonful of glucose that you have poured into the sublingual space has been absorbed completely before you pour in the next scoop. The best treatment, however, is 25% glucose, 2 bottles rapid IV. Once the IV line is established, that produces rapid glucose estimation levels going up in the blood, and then the patient comes round fast. Now, there are a few blinkers in here. As I said, don't ask anything to be swallowed because these patients choke very easily. Keep talking to the patient, even if the patient does not respond, and make sure the glucose is absorbed from the mouth itself, because once it gets to the GI tract, then the glucose will take time to get absorbed into the system. Coming round from hypoglycemia is dramatic and fast. And if it doesn't happen that way, you are not encountering the hypoglycemia. Consult a physician and get in touch with the hospital that you are attached with and have the ambulance set in ASAP along with a pharmacist. The next condition would be the pulmonary predicament, the lung conditions that can happen. There are 2 notably. One is bronchial asthma that we very commonly encounter irrespective of the age of the patient, and the other, again happening in the elderly age group, is COPD. With bronchial asthma, the bullets are, it is episodic and it is basically an allergic condition. It might lead to status asthmaticus right in the middle of your surgery. I have had an experience of this. I have had an experience of this where the patient landed up in status right in the middle of the surgery. We had to give IV hydrocort. We had nebulization. After forming the anterior chamber, the linen was withdrawn. The patient was on the table. The patient felt better after 15-20 minutes. We asked the patient to lie down again and completed the surgery. So this can happen to anybody. However, with bronchial asthma, interestingly, after you cover the face with linen, these patients are less claustrophobic than their counterparts, the COPD group, which often for more claustrophobic, because in COPD, the lung loses its elasticity, which is permanent. It does not expand unless they do some breathing exercises regularly. Most of our patients have this. The other thing that perhaps even complicates the situation more is they are obese and the breathing is abdominothoracic than thoracico-abdominal. So the diaphragmatic movement is also lessened, and that is that adds on to the claustrophobia, because once they lie down, the diaphragmatic movement lessens even further, giving rise to the condition. Now, these are 2 simple gadgets that you can keep in your setup in your hospital. I have this spirometer. This is the spirometer. This is the peak flow oximeter. The peak flow will give you the red, yellow, or green signals. The patient blows into it full blow, and you can know what is the vital capacity of the lungs roughly. But the spirometer is a rough estimation though, but it can give you an estimation of both inspiration and expiration. You just have to reverse the spirometer and ask the patient to inhale. The first ball always goes up. This is the first ball, the red one. If the yellow one climbs up, by 20% also the patient is doing fine. You are safe to take the patient. This patient in all possibilities will not be claustrophobic under the linen. This is what my experience suggests. And if the patient can blow out to the third wall, fantastic, nothing like it. So these are the basic preliminary things that we can do. However, before OT, I used to administer intramuscular teriparatide earlier on, but leads to disturbing tachycardia in some patients who have completely given up that habit now. You can, however, give nebulization if you have an established case of COPD. If the patient has a COPD, you can give a combination of salbutamol with ipratropium, which comes as the brand name of Duolin. Is very commonly spelled out in our industry. It has to be only salbutamol in bronchial asthma. They don't need the support of a cholinergic drug to relieve them of the possible bronchospasm inside the OT. You must have a facility for simple flow oxygen in terms of oxygen cylinder and an attachment. However, oxygen supplementation for a long time is contraindicated in COPD, as we all know and can refresh our general knowledge with, because the oxygen supplementation going in for a long time can actually depress the respiratory center. So we have to be careful. They can be given a short burst of oxygen for a 15-20 minutes period, but then you have to wean them off it. Injection Primacort and Ivaline should be kept at the ready at the pharmacy or at the refrigerator again at all times when we are handling with seriously aging patients. If you want to attach a pulse oximeter inside POT, I would always recommend that you switch the alarm off, the beep off, because that sometimes scares the patients. So we tend to keep our operation theaters as quiet as possible. It's coming to the anticoagulant algorithm. There are many anticoagulants used by our physician counterparts. But when you do a phaco, the small capillaries are injured, if at all, because we enter the nimbus. So the agents that are antiplatelets they can be withdrawn, notably the low-dose aspirins and the clopidogrels that are given to our patients. But the antithrombin or clotting factor prohibiting agents may not be stopped. We don't need that. We just need a small plug of platelets coming and clogging the area from where the oozing is taking place. We do not need any drug to be withdrawn that causes a thrombin inactivation or a clotting factor inhibition. However, if you are into SICS, where major blood vessels are likely to be damaged, where you're constructing tunnels or other procedures like strabismus surgery or retinal procedures or orbitotomies and oculoplastic procedures, all the anticoagulants should ideally be stopped for a period of 7 days. In COVID situations, we are seeing our patients receiving a lot of anticoagulants, and in fact, this happened to me very recently. One of my patients was admitted and was receiving low molecular weight heparin. He had to undergo a phakic IOL to get it done the very next day of cessation or withdrawal of low molecular weight heparin. I asked my physician, I did not have any knowledge about that. I asked my physician whether I can go ahead and do it. He said, yes, you can, if the heparin or the enoxaparin has to stop for 12 hours or a little more than that. Fondapyrinox is also another agent which is being very commonly used now for COVID patients, but this has to be stopped for 24 hours. This is a little longer lasting. If you need an emergency surgery for ophthalmology, of course, this is not very valid, but if you need an emergency surgery, if the patient is on Fondapyrinox, then there is no reversal agent. The patient is on heparin, you can give a bout of fresh frozen plasma which supplies clotting factors to the patient, and then you can take up the patient. If the patient is on warfarin, and a lot of COVID patients after withdrawal or cessation of low molecular weight heparin are being continued on warfarin. If the patient is on warfarin, please do not take up surgery before the PT-INR normalizes. So it should ideally be taken after the PT-INR normalizes. So now coming to, these are about a few important conditions. Now coming to a mixed bag of situations that you might encounter in your day-to-day practice. And these are individual patients for which you have to plan individual. Like, for example, on the left side, you have a 47-year-old lady who is a patient of poliomyelitis and a bilateral mature cataract she is not even able to fix, as you can see here. And she was taken up last week for a topical phaco, doing pretty well. The lady right in the middle is a patient of Parkinsonism. You can see the chorea, the atherosclerotic movement. She chose a flax for herself, and believe me, it was a daunting task for me to dock the PI on the eye to perform femtolaser on this patient. The one on at number 3 is obviously a patient of severe kyphosis. The leg end is raised and I have to operate on standing positions. You must have encountered all these patients in your practice as well, and you must have, I'm sure, planned for them on an individual basis. Before we sign off, this is also an important aspect that we talked about, since Satyajit wanted me to highlight a bit on this. This is again an individual kind of crisis management when you have a loggerhead with patients. Now, when patients come to you at very frequently, you face FAQs from them. Now, FAQs in this regard is not frequently asked questions. I have subgrouped FAQs into 2 broad categories. One of them is fact augmenting queries coming from patients, which is fine, They come to you, you keep on explaining, and that builds the one-on-one relationship between you and the patients. Unfortunately, almost 99% of our patients fall into this category. And usually the number of queries falling in this category range from 3 to 5. So you don't mind answering them on any given point in time. The other category, however, is physically annihilating quizzes. This comes from the rest 1% of the patients. The number of questions raised from horizon to infinity. And while they ask these questions, you slowly notice the voice changing to a more firmness, a few of the sarcomeres, the muscles flexing, teeth clenching, and they virtually transform themselves into a raging bull. What you should be ideally doing when there is a raging bull looking at you is what this gentleman is doing. Take it head on and slap it a few times, not with hand, but with words. So have a clear-cut territorial differentiation. Let the patient know. This is my suggestion, of course, this is very personal. Have a territorial differentiation. Let the patient know that this is your domain and only you are allowed to speak when this domain strikes. You must have a technocrat's arrogance, what I call as a technocrat's arrogance. I've studied for 15 years. I've invested 15 years of my life studying this thing before making out a statement. This statement has to come out bold and loud and clear with the letter size 60. Explain what is explicable and ridicule the encroachment. If somebody is trying to encroach upon your area, let him know that it is ridiculous to encroach into your area since you are a technocrat. I came across a patient very recently who was on the second category, who was asking me feverishly annihilating quizzes, and he asked me which IUL should I offer. Should it be G's or should it be ASIUS? I could not make out what sense he was making. Ultimately, I understood for a while what he was meaning essentially was Zeiss and Acrisol. I told him all I could. I explained him all I could between the material differentiation, but I failed. Then that was a point in time I realized the more you try to convince people, the more they'll oppose you. So it is better that the choice is left on to the patient with a stand note that it is your choice. You are responsible for the pros and cons. Don't come back to me to blame for the thing that I had chosen for you. Thank you so much, ladies and gentlemen, for your kind attention. Thank you so much, EIZOC, for the platform. Signing off.
Thank you, Dr. Anurag Mishra, sir, for very informative and very good presentation. Next, we have our very esteemed team of panelists, Dr. B.P. Kashyap, sir, Dr. J.G. Agarwal, sir, Dr. Swaraj Bhattacharjee, sir, Dr. Saroj Tripathi, sir, and finally the golden comments to be made by Dr. Biraj Goswami, sir. So first, I would request Dr. B.P. Kashyap, sir, to kindly give your valuable comments on the topic.
Thank you, Jima. Thank you so much. Thank you, Satyajit. Thank you to have given me this opportunity. To be very frank, Anurag, it was very illustrative and very, very nice presentation. But then I feel that we are ophthalmologists. We can't do so much about the what was the most difficult thing in my medical life was read the ECG and I could auscultate a lot of things, but the ECG was the toughest thing. I feel that you know I have a little presentation. Can I show it?
Yes, sir.
Yes, sir. Yes, sir.
So to my mind, what ophthalmic emergency, just to show you that, the clinical establishment act, people say that if there is some case of head injury, if you go to the eye hospital, what do we do? It is nothing much. The only thing is you have to stop the bleeding, allergy, pain and all that. So if the patient comes to you because your hospital happens to be near the highway or near the main road, so if something goes wrong near the hospital, they come to you, then what do? You must have a ramp near to enter your hospital. This is a ramp where you make the patient to enter, and then the patient should be given the stretchers and the wheelchairs so that enter. You always have to have one emergency room. So we have emergency room at 12 o'clock in the night, and this is the emergency room in which we have got everything to do, like doing the bandage and stopping the bleeding and give the tetanus injections, and the patient is, they feel better, that they are given some kind of a first, and the patient is transferred to the other hospitals. And so the patient, when we operate the patient, when we see the patient in the OPD, we always take the blood pressure and temperature, SpO2 pulse testing, etc. with the ophthalmic initial assessments. And one of the major issue in our place is electricity. So there should not be any problem because of the electricity. So you have to have, the gen sets and transformers, and then you have a lot of UPS, many of them with the very, very heavy, this thing, all 10 kV and above, and then you have got inverters. And we ask the patient to go for medical fitness for this surgery. This is essential. There's the probably EIZOC guidance also tells us to go for the medical fitness, and it should not be done less than MD medicine. So after the medical fitness, if you feel that the patient has got a higher risk, we stamp it here that the patient is a high risk case, and you have to define yourself what patient do you consider to be a high risk. I don't want to take any chance the patient has got some cardiac problem or a asthma problem or any other problem. It's their problem. They should tackle it. I call them. So if there is any hard risk patient, most of my patients are being operated under the care of the anesthetist. They don't give the anesthesia, but the anesthetist is present. He notes down everything for me, and it's I aram se mein fir operation karta hu. And then if the patient has got certain other conditions like cardiac patient, then the team is with ophthalmologist. There is an anesthetist and a physician. And we have, if there is any problem, we have a cardiac defibrillator, and it has to be charged every time, and you should know how to do it. Then we have a anesthesia trolley in cases of if the patient has got is high risk patient. We keep the anesthesia trolley inside with all the emergency medicines ready to be given, and we have got CPR kit in each and every floor of our hospital. Then we have a place for the ambulance which is designated, and in which you have all these materials like oxygen and suction and everything. All the medicines are there in the first aid box, and there's a well-trained person for the advanced resuscitation, and the patients are transferred to the nearest multi-specialty hospital, and they give our cases the priority. And emergency are also there if there is in a FFA room when the patient has got, most of the time they get a vasovagal attack or some kind of allergic reactions. So we have medicines then there ready for the FFA cases. And we have got a regular CPR training, and we train our staff, and we call, invite other people also. We invite even police people to come to learn about the CPR, how to give it, what is to be expected. And we have code blue mock drills. So if there is any problem, what do you do, how to go about it? Somebody notes down the things that...
Sir, I'm sorry to interrupt, sir, because we are way behind time. We needed your comments about Dr. Anurag's presentation.
Since his speech was something about heart, and it was very difficult to follow for everybody. I thought this is what I follow. So anyway, these are the things we should be taking the fire emergencies also. and you should have a facility for the fire tank, water tank also, and you should do the mock drills. And sometimes with the patients, they do not pay the money, and then you should be ready for that when the patient comes by and how to go about it. So what I want to tell you is the Dr. Anurag paper was good, very nice, but then I personally feel that I will not like to take those responsibility myself, and neither probably it may be good in the court to prove that we have done everything. We have to take help of the anesthetist and the physicians, so they help you out so that you are comfortable, you are at ease while you are operating, giving the best to the patient for as far as the eye is concerned. Thank you.
Thank you, Kashyap sir. I request now Dr. Agarwal sir to kindly give your opinion.
Thank you to Satyajit and Dr. Pranav to give me the opportunity. And as far as Dr. Anurag's presentation was there, it is an excellent presentation. It is very much elaborate. But it is very difficult for me, at least at the age of 60, to go for ECG training fresh, because it is very difficult to interpret the ECG. And another thing that what I feel in my 30 years of practice, that there are some emergency comes, just like a FFA, and sometimes in anesthesia, and sometimes even in the antibiotic drops and hydrolysis injection, sometimes in pediatrics like atropine, and even in myotics. I usually prefer that during these anaphylactic reactions, that is type 1, we should prepare ourselves to manage it, and we should be ready for to assess the patients and to evaluate the respiratory signs, cardiovascular signs, exercise signs, and then we go for the treatment like adrenaline, chlorpheniramine maleate injections, and hydrocortisone, and dexamethasone, and other oxygens and other other intubation instruments. And this is very important because if at this point of time we should be we should keep our OT fit for, with the treatment to give the treatment for this anaphylactic reaction. And what is sometimes I have also come across the hypoglycemic patient. Sometimes patient comes to our hospital without any breakfast, and then he also, especially in diabetic patient, he also takes the anti-glycemic drug also that may give time some severe hypoglycemia, and at the operation table it becomes very discomfort. This should be we should be looked for before the OT started. And at one time I was very unfortunate that one of my patients is an elderly patient who was very normal, and then after during operation, at the mid of the operation, he has developed some discomfort and suffocation. I immediately stopped the operation and then called the relatives, and I think I just assessed that his blood pressure and the pulse rate is not normal. Then it is very difficult for me to call any physician. I immediately transferred the patient to the nearby medical colleges. Then he can, then at that time, she was managed, and after recovering, then I go for the complete the operation. So these are the some problems in medical emergency that we usually face during the part of our operation. So and it is very difficult, by what the Dr. Anurag Mishra has said, but it is really very elaborate. but it is very difficult to follow. So we have to be at least some medical kits were there, and then if any emergency comes, then we have to consult our physician or anesthetist. And what Dr. Kashyap has pointed out, that we should not take bother to every medical aspect which is not in our domain. Better to pass out to the anesthetist or any physician for this type of management. Thank you, Tom.
Thank you, Agarwal sir. Next, I request Dr. Swaraj Bhattacharya sir to kindly give his comment.
Good evening, everybody, and thank you, Dr. Satyajit and Dr. Jhumur. Actually, in my center, what Dr. Anurag has said, it was excellent. Probably a revision of my MBBS classes where all these emergencies and post-patient classes, it was really just refreshing of all those data. What I feel, in cases where the patient is a little aged, maybe 70 or 75 years, to save our own skin, I think a medical opinion is have to be sought before the surgery. In my center, what I does is we have a very small center. We do the preoperative checkup, as everybody said, like SpO2 and this blood pressure, sugar, everything we do. And in particularly in diabetic patient, we ask the patient to have the full breakfast. And in cases where the patient's education level may not be so good and they might miss of the situation, I ask them not to take the medicine in the morning. Instead, after the operation, they might, because we used to do in morning operation, so after the operation, they take the morning dose. But during the surgery, if the sugar level is little high, it is not going to hamper so much. So this is one, in my opinion, I think this can be done. And about the ECG and all in old age patient, it could be corrected. If anything is, any opinion from the cardiologist, etc., can be sought. Any non-ophthalmic emergencies like what Dr. Kashyap was telling us, in all other emergencies like fire and those things, we might set ready. And one more thing, for permission of the center, we need to have a on-call anesthetist as well as an on-call medicine specialist. At any point of time, we should call them and they will be helping us. Of course, in the hospital premises, the oxygen, the emergency tray, and etc., all should be kept ready. That much from my side.
Thank you, sir. Next, I would request Dr. Sir comment on the topic. Dr. Saroj Tripathi, sir.
Jhumar, he has gone for some urgent work, I think. So can we request Dr. Biraj Goswami, sir?
Yes, sir. Dr. Biraj Goswami, sir, kindly give your golden comments on the topic.
Okay, I don't think he is around. Okay. So I would like to thank Dr. Jhumar at this point of time for doing the moderation. And I would like to have the opinion of the senior panelist, starting from Professor ASB Sahai, sir. Sir, if you are around, we would like to have your comments, short comments on both the presentations, sir, please. I would like to move on to Dr. R.C. Meher, sir. comments about Dr. Anurag Mishra's presentation, which just finished a while ago?
Thank you, Satyajit. Actually, I was out at some time. Luckily, I am in. And I'm audible?
Yes, sir. Yes, sir.
Am I audible? Okay. I must congratulate Dr. Anurag to give such a wonderful lecture. He has taught us a lot of cardiology, which of course, I agree that the tracing should not be sick understanding of the tracing. But to me, as I totally agree with Dr. Kashyap, that to me the most important aspects are, number one, having an anesthetist around. There are several reasons that ocular cardiac reflex can come at any moment whenever that is not behaving properly, either inhibition or dilation. Even under topical anesthesia, it is more. So anesthetist should be around to look after all these cares, because medically he is more competent to take the medical care of the patient than us. And of course, I will take care of the ophthalmic part and he will take care of the physical part. That's the simplest thing coexistence. Number two, medical fitness by a physician to rate the patient's high risk or low risk, very important. And as Dr. Kashyap has said, ramp and wheelchair and trolley, these are also extremely important things to be there in the OT. Now, other important, yes, so there should be multi-parameter monitor. Even if we do not know ECG, we should have the pulse oximetry, ECG and BP. That is the multi-parameter monitor. We should have a B type of oxygen cylinder, and we should have an ambu bag, so that at any case of emergency, through the ambu bag, we can create a status of ventilation to the patient. Yes, knowledge also. We should have a suction machine with a suction cannula, because some may have choking. Then intubation facility and with the laryngoscope and all should be there in every OT. Whether there is a regular general anesthesia cases are there or not. We should have some medicines compulsorily in the OT. There is atropine if there is the person is having bradycardia, dexamethasone if the person is having, of course, salbutamol spray. We should have a beta blocker for any tachycardia or supraventricular arrhythmia. We should have an injection Lasix for any patient which is suspected to have the signs of congestive cardiac failure. And we should have an IV cannula ready, because all the medicines should go intravenous. A hypoglycemic patient will be properly treated if we are giving 20% glucose intravenously. And a propped up chair should be there in the OT. In the room adjacent to the OT. A propped up chair. Because many patients need that at the crisis hour. So these are certain things. And then again I am telling, our anesthetist should be around whenever we are doing the surgery even with topical anesthesia because of the risk of the oculocardiac reflex, because most of the patients are geriatric. Thank you so much.
Thank you so much, sir. I would like to request Dr. Satyajit Pal. Dr. Satyajit Pal, sir, are you there? Okay. Can we have a short comment from Dr. Nagendra Prasad, sir, please? Dr. Nagendra Prasad. Can we have a short comment from Dr. Roman Singh, please? Dr. Nagendra Prasad, can we have a short comment from you, sir?
Yeah.
About the second presentation.
Yeah. I like to consider Dr. Anurag for the elaborate presentation, but he has done lots of medical part, medicine part, like if we have gone through a PG days, as Dr. has already told. But we must, the point elaborated by Dr. Anurag is very valid, and we must know about all these things if you are in a medical profession. But in practicality, it is not happening. What happens to be on safer side, go for the patient physician fitness, cardiac fitness from the physicians, and anesthetic should be in the OT whenever you are going to operate. This is no excuse without anesthesia. But in practicality, we all not going to have anesthetic while operating on the eye surgery. So in practicality, it should be the rest of the things is discussed very well. Nothing to add much more. That's all. That's all. Thank you, Sajid.
Thank you, sir. Thank you, sir. Can we have the comments of Dr. Roman Singh, please? Can we have the comments of Dr. Y.C. Mehti, please? Dr. Y.C. Mehti. Dr. Tathagat De. Dr. Tathagat De, sir. Can we have the comments of Dr. S.K. Mitra? Okay. So I'll just turn around and come back to Dr. Vibhuti once again, and would like to request him to give his comments about the two papers. A short comment from you, Dr. Vibhuti, please.
I'll just make a comment on Anurag presentation. His presentation was an excellent one. We just can't escape our responsibility as a physician, as a surgeon, that we don't know and everything has to be handled by someone else. Since we know 99% of the practitioners are single-time practitioners. They are not even running multi-speciality hospitals. They are not having enough of armamentarium, of enough of support system like Kashyap sir to have that kind of equipped hospital. So we have to be prepared. My dictum is one. Go slow when you are operating upon a complicated patient. Give little bit of time before the patient settles on the OT table. And if you find out that patient is not very comfortable, just beware of that something might happen and you need to be prepared. Like what we do in a posterior polar cataract. We get mentally prepared ourselves for handling a complication. In a similar way, a patient lying down on a table and breathing heavily should make you alert that this patient might give you a sleepless night. So be prepared for that handling. But rest of the things, rest of the armamentarium which you need to have in your OT, like oxygen supply, like the emergency tray, trolleys, and defibrillator, they need to be there. They are basically of medical legal issues also. So excellent presentation, and I must congratulate. You have taken us back into all the important finer points we must remember. Yeah, we can not employ every time which what you taught, but we need to know that. Thank you very much, and thank you very much everyone for a wonderful evening. And love, your presentation was also excellent one. And the building looks awesome. Regarding the group practice, Devashish sir is there, so I must not say much. But my point is, the day you are prepared to listen to your companion or the person who are colleague who is there, and before doing anything, you must recognize that your act is not going to create problem for him. Your group practice is going to run. Even in our government center, like regional institute, we have to think in the similar way, then only we will grow. Thank you very much.
Thank you so much, Dr. Vibhuti. I'd like to request our president, Dr. Abhijit Ghosar, to please give his comments about the two presentations, sir, please.
Thank you, thank you. Regarding the presentations were awesome, wonderfully done. Love and Anurag, thank you so much. As for the practice, I would say one thing, especially to the young people, that the first thing you should have, you should build up a good reputation. As you sow, so shall you reap. Whatever you do in young ages, you have to be honest and ethical to your profession. There are many avenues now which are so glamorous that you are forced to go astray. There is no doubt about it. But friends, believe me, if you are honest and ultimately an honest and ethical practice pays. Whatever you do, this is my suggestion, just try to be honest and ethical. And regarding the second talk, it was wonderful. I think you did your cardiology a bit, I think. Because I think you were a cardiology house staff or something where you must have done it. Is it true?
Sir, I would just like to respond to that in a bit, Satyajit, if you allow me a couple of seconds. I did not do my cardiology, sir, but as I said, I did my homework before I started my own hospital. I knew that I'm going to be standalone. I knew that I would not have the services of an anesthesiologist all the time running in my hospital. And just for the knowledge of everybody, the law does not state that you have to subject your patient to an evaluation by an MD medicine for him to qualify for surgery. The law states that you have to do your groundwork properly. It does not look at the qualification of the person who is doing the groundwork or the preoperative evaluation. You yourself can jolly well go and do it. So these are not very difficult things to accomplish. Yeah.
One thing I'll tell you, in the next conference of the EIZOC, we are going to have an instruction course by you how to read ECGs.
Certainly, sir. I would love to.
That was sure. Pranav Jain and Devashish, please put up a thing. We are all
I
there.
would love to.
Excellent, quite informative.
The next thing is that about, though we do in topical, we used to do a lot of xylogen thing. And the dangerous thing was xylogen shock. I think it occurs very rarely, but one should be conversant with this idea somewhere. Because some people read injections still now. And next was a nervous patient. Suddenly the patient goes clammy and you're alone. How to do? This is a very important thing which you do. And the next thing, we used to do a lot of detachment surgeries and squint. And the dangerous was this bradycardia. It was a dangerous thing, though still a few buckles have been done, but squint surgery, I remember a teenager, what a radical bradycardia occurred. And we knew we had to give atropine and tegaderone, things like that. So these are very important. Arvind, I think you will go by it. But one thing, Anurag, I have to tell you, one thing I don't agree with you. Doing a fake IOL in a patient who's been using heparin, it's not an emergency that way.
It wasn't for me, sir, but the patient
I could agree, but you could have held it a bit.
I did not say I did it, sir. I just said the physician friend of mine said you can.
But did you do it or not?
I'm not going to open up after your comment.
No. So thank you so much. Thank you so much. Thank you so much.
My PG, I've seen one patient collapsing after just putting 4% xylocaine in the eyes.
Yeah.
And luckily, the cardiologist was called and he confirmed that the patient was his old patient. So everything was settled. Otherwise, there would have been some problem also. So that was the case.
Before I go to Dr. Pranav Ranjan, can I request Dr. Devashish Bhattacharya? He wants to say something.
It's just a brief comment. It was a wonderful lecture, Anurag. Thank you very much. One thing is, we have been talking about atropine, and actually in Disha, it also occurred in my practice. We always give 1 drop atropine to dilate the patients, because most of the patients will have some vasovagal, except the patients with prostate problems. So we give atropine because that prevents the vasovagal problem. See, 1%, 1 drop contains more than 1 injection actually. 1 injection is 1 ml of 1 in 1,000. So this is one thing which has saved us of lot of these, cardiac emergencies. And another catch-22 situation is the bifascicular block, where the patient didn't have a syncopal attack. Now, the cardiologist won't do a pacing, and you cannot do the cataract surgery. So where do you go? So the best thing is to put an IV, put an IV channel, and of course you have a physician or an anesthetist by your side for these cases at least, so that they can give isoprenaline if required. So.
Thank you so much. Can I request our secretary, Dr. Pranav Jain, sir, to please give his comments about the two topics?
Both the topics, both the speakers were fantastic, Dr. Lau and Dr. Anurag. Dr. Lau, I think I have learned few things from you, your presentation. Number one, the decor of the interiors of the clinic. I'm going to change that, number one. Number two, soft wearing. And number three, have an eye on the social media to improve your image. These are the three things I could gather from your, and this is I going to implement. And from Anurag, he was absolutely fantastic. He made us a cardiologist. What I'm going to learn is how to interpret the ECG, definitely for sure. So it was a great learning curve for all of us. Thank you so much.
Thank you, sir. A quick comment from Dr. Sujoy Samanta, please. Dr. Sujoy Samanta. Okay, if we don't have him around, I'd like to request Dr. Gunasagar, sir, to please give his closing remarks, sir.
In this webinar of Voice of the East Extra Mile, actually we have traversed the extra mile quite successfully with this topic of Dr. Love and Dr. Anurag. We think in future also we will traverse the extra mile with many more other topics. Thank you.
Thank you so much, sir, for your words of wisdom. I'd like to request Dr. Debashish Das to please give the vote of thanks now for this program.
Ma'am, I'm honored to give the vote of thanks for today's program. At the outset, I'd like to thank our two speakers. Both are so magnificent in their presentations. One of the points what Dr. Love have taken up, but there was no scope for discussion in this program today, is the role of the TPA regarding the cashless facilities. I think that should be taken up in some of our future programs later, because we all must be knowing the Mumbai medical emergency medical doctors have refused this cashless facilities, and we in the eastern zone have no say of our own and had to depend on these TPAs for our cashless facilities. So this is one point. And Dr. Anurag, I'm love to know the new terminology, technocrats arrogance. I'd like to implement it. I'd like to thank our moderator, Dr. Satyajit Sinha. He has been working with it for over a month. Dr. Vibhuti and Dr. Jhumur Chaudhary for conducting the programs. I'd like to thank the special invitees for today, Dr. Maipal Sachdev, our Honorary President AIOS, and Dr. Namrata Sharma, Honorary Secretary AIOS, for adding more glamour and prestige to our EIZOC programs. We would love to have them again in our future programs. I'd like to thank all the panelists today, Dr. B.N. Gupta, Dr. Rotish Pal, Dr. B.N.R. Subudhi, Dr. Rajan Anand, Dr. B.P. Kashyap, Dr. Joybir Agarwal, Dr. Swaraj Bhattacharjee, Dr. Saroj Tripathi, as well as the special golden comments from Dr. Devashish Bhattacharya and Dr. Biraj Jyoti Goswami. I'd like to thank my president, Dr. Avijit Ghosh, and my secretary, whose brainchild is this meetings we are having every 15 days. Thank you so much. And I'd like to thank at the last my sponsors for today, Entot, and I'd like to highlight one of their products, phenocane injections, which is given intracamerally for an immediate dilatation of the pupils. There are two advantages of this phenocane intracameral injection. First of all, the pupillary dilatation is as big as 7 to 9 millimeters, and it is achieved within a span of 20 seconds. I think this is one of the basic ingredients in our armamentarium in the operation theater, which we should be taking advantage of in our surgery. Thank you so much. Thank you everybody for this whole program. Just one point I was noting as I was going through this meeting, our viewership in this webinars decreases sharply after 9:30 p.m. That's what I was noting silently in the back office. So up to 9:30, I think it's high time we should gear up our belts. After 9:30, the viewership sharply decreases. And I saw Dr. Satyajit Sinha asking for comments, and our own delegates were absent. So I think that rings us a bell. We should know where to stop, how to stop. Thank you so much.
Yeah,
Thank you so much. I would like to take this opportunity to profusely thank our Secretary of AIUS, Dr. Namrata Sharma, one of the most dynamic secretaries we have had in All India. Who is with us right till the end. Thank you from the core of our heart.
She's there all the way. Really, it's nice.
Thank you, Dr. Namrata Sharma, ma'am.
Dr. Namrata, yes, staying with us from beginning to end.
I tell you, could we give 2 minutes for Namrata to share her comments?
Yeah, exactly.
Sir, yesterday when I talked to her, she told me she'll be right through the end of this webinar.
Can you give your comments, please?
Ma'am, please unmute yourself. Ma'am, please unmute yourself.
I remember I made Namrata the member of EIZOC at Shillong.
I know, I remember very well too. And out of the box ideas, the most impressive were the two talks today, I think. And this is something which is not given in the books. This is something which we cannot, learn on our own. And if we learn by making mistakes. So this is something which we share and we learn from each other. So out of the box ideas, and both the two talks, okay, I think it's a great idea to have, to focus on two topics like this and do the whole webinar, rather than, and giving time for interaction and giving time for talks. So excellent, I think. And we should, like Dr. Abhijit Ghosh sir also said, that we should make this a part of not only EIZOC, but also I think we should help Dr. Partha to make it a part of his program when he makes it for the AIOC as well, which is going to be in Calcutta next year.
Anurag will be there for sure.
Yeah, Anurag and Love both.
Thank you so much. Thank you, ma'am, for kind words.
And one thing, Anurag, please add, please do ECG of the surgeon also while operating. And
that's a great thing, yes. That's quite essential.
Something which you should do also.
That has gone for an attempt bradycardia in COVID.
Dr. Namrata, are we going to have
Debashish wants to say something, please.
No. It's just a parting joke. I mean, what is a double-blind study? When two ophthalmologists are trying to read an ECG, that is a double-blind study. You are trying the wrong.
I think Debashish, if you remember, Ravi Thomas made a presentation of doing the cardiologic test for doctors. It has been done by Ravi Thomas.
So whenever there is a
and it was a dangerous situation. You could see what was happening inside you.
Whenever there's an emergency, even in the hospital, and you are looking at other people, you're looking at anesthetists, call the doctor, it's like that. Even in airplane, if there's an emergency, you're looking the other way around, and thinking that we'll only go when they can't find anybody else. We don't know what to do. So
Dr. B.N. Gupta, sir, you have a question?
Yeah, I have made one emergency in aeroplane and 5 emergencies in trains. Dr. Namrata, you were just telling that next year we are going to have a AIOC in Kolkata. Is it sure?
Yes, of course, we are going to have it in Kolkata next year. Next year is Kolkata's turn to have AIOC.
No. And what about dates?
Dates is something which we have to finalize. So I think we've called a GBM for that. In the current era, I don't think it will be possible to have it in February. So we have to take a call on it.
Okay. Thank you.
Regarding the ECG, Satyajit, whenever you ask your patient, have you got your physician evaluation done? They'll bring out ECG, sir, ye dekh lo, sir. So then you have to say ki it is like Pandra for me also.
Ye dekh lo.
And many a times patients of headache, they come with easy report. Now use handle.
And
Thank
we
you
haven't discussed the last emergency, how to handle deaths.
Vibhuti, it's YouTube Live and Facebook Live.
No, this is a thing which we are going to have in a instruction course. That's for
But
sure.
I believe you must have some basic knowledge of ECG. I think I see.
You know, I had been to a dentist with my son. I was an attendant for my son. My son was the patient. And while we were walking out of his chamber, he suddenly showed me an ECG printed paper. And I said, who's it? He said, there is a patient who is lying down on that table. I'm going to do a root canal treatment. Please look at the ECG and tell me whether I can. You know, it's that kind. So, I mean, he somehow knew me and he knew that I can read ECGs. So you also have some amount of reputation building for yourself to read out ECGs as an ophthalmologist.
And what Devashish has said, I agree. The next subject is going to be, how do you deal with death?
Actually, Dr. Anurag has shown us today, actually, what are the things might happen. Because we are thinking in a haphazard way, no? But one by one. This is really excellent. Thank you, Anurag, for
Thank you, sir.
refreshing our brain, actually.
Thank you very much. Thank you. A big thanks to everybody, all the participants who were there today. A big thanks to Dr. Jhumar Chaudhary who assisted me.
Thank you.
Thank you to all the panelists, all the participants who were there today. A big thank you. A big thank you to Dr. Pranav Jain for giving me this opportunity.
Thank you.
Thank you,
Everyone, thank you, Satyajit. The meeting.
Thank you, Dr. Buddhi, sir. Thank you,
Good night.
Dr.
Good night.
Sir.
Good night.
Thank
Good
you,
night.
Dr.
Good night, Viraj. Good night.
Good night, all of you.
Thank you, Dr. Love, and thank you, Dr. Anurag Mishra, for the amazing presentations that you made today. Thank you, Dr. Vibhuti. Thank you so much. Thank you, everybody. Thank you, Dr. Pranav Ranjan. And thank you, Namrata ma'am, once again for being with us. Thank you so much. Thank you, Viraj, for coming, sir.
We can
just one announcement, sir, I have to make, sir. For the next webinar, it is not going to be probably on the 18th because of Diwali and other festivals. So it is going to be 1 week later on the 25th of November.
Whose turn is this? Jharkhand?
This is going to be hosted by Jharkhand. Yeah. So instead of 18th, we are going to probably have it on the 25th.
Okay, Jhumur, can we say hello to the young one, please?
Hello to everybody and good night to everybody.
Good night. Good night.
Thank you, Ramanji, for all the help and support. Thank you, Ramanji, from Dot. Thank you so much.
I'm going to learn ECG. Definitely. Next time I see you, I'll tell you what ECG is all.
Thank you so much, sir. My pleasure.
Thank you, Anurag. Thank you, Dr. Love.
Good night, Dr.
Thank you, sir.
Nice to see you.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am. Good night.